Let's dive right into this explainer because today we're exploring what is honestly one of the most mind-blowing success stories in modern medicine, the near eradication of hepatitis C. It's not every day we get to talk about a disease completely transforming from a lifelong, complicated burden into something we can definitively cure in just a matter of weeks. The whole journey, from discovering the virus to decoding its unique machinery and finally developing a universal cure, is just absolutely fascinating.
Here is how we're going to break it all down. First, we'll look at the modern medical miracle itself. Then, we'll decode the virology of hepatitis C, track its transmission and slow progression, figure out how to avoid a really dangerous diagnostic trap, and finally, look at the 12-week universal cure.
All right, Section 1, a modern medical miracle.
99.7%. Let that sink in for a second. That is the modern success rate of a simple 12-week oral therapy against hepatitis C. Just think about that. We're talking about a discovery that won a Nobel Prize in 2020. It turned a virus that used to be a leading cause of chronic liver disease, cirrhosis, and liver cancer into something we can cure almost 100% of the time. This is, without a doubt, widely considered one of the absolute biggest achievements in medicine this century.
So the absolute game changer here is that we aren't just talking about managing the disease or survival anymore. We're talking about a sustained viral response, or SVR. SVR means there is a complete absence of hepatitis C RNA detectable by PCR. The virus is entirely eradicated from the patient's system. It's not just suppressed, it's completely gone. It is a total victory over the disease. Moving on to Section 2, decoding hepatitis C virology. To understand how we get that cure, we have to look at the virus itself. Hepatitis C is part of the Flaviviridae family, and it's a positive-sense RNA virus. But here's the really wild part about how it gets around. It travels as lipoviral particles. Basically, it cleverly hitches a ride by binding to VLDL and LDL cholesterol. Because it's literally traveling with fat, hepatitis C is uniquely linked to hepatic steatosis, or fatty liver disease, way more so than other viruses like hepatitis A or B. But the virus's biggest vulnerability, that's all about where it replicates.
And that brings us to the exact reason total eradication is actually achievable. There is zero integration into the host DNA, literally none. Because the hepatitis C virus replicates purely in the cytoplasm of the cell and never sneaks its way into the host's chromosome, we can completely eliminate it. It's not like HIV or hepatitis B, which can hide deep in our genetic code. Hepatitis C leaves itself totally exposed right there in the cytoplasm.
So scientists looked at this machinery and literally cracked the code for modern antivirals by targeting the virus's non-structural proteins. The virus uses specific proteins to survive and copy itself: NS3, NS5A, and NS5B. Modern medicine went ahead and created targeted inhibitors for each one. And there's a brilliant little naming convention here to help you remember them. Drugs targeting the NS3 protease end in Previr. Drugs targeting the NS5A RNA binding site end in Osvir, and drugs blocking the NS5B polymerase end in Uvir. Previr, Osvir, and Uvir. That simple code right there is the backbone of the modern cure.
Okay, Section 3, transmission and slow progression.
Now, what's genuinely fascinating about Hep C is how it behaves compared to other hepatitis viruses. A massive 85% of acute hepatitis C cases turn into chronic, silent infections. Only 15% of people naturally clear the virus. If you look at hepatitis A or E, chronicity is 0%. Even with hepatitis B, chronicity in adults is super low, maybe around 1 to 5%. But hepatitis C, it is overwhelmingly a chronic disease.
So how is it actually spreading? The incubation period sits around 50 days, but clinically, our radar needs to be locked onto percutaneous spread, meaning transmission straight through the skin. This puts IV drug users and chronic kidney disease patients on dialysis in the highest risk categories. It is vital to note that sexual, perinatal, or breastfeeding transmission risks are practically negligible. And hey, thanks to modern screening, the risk of getting it from a blood transfusion today is incredibly low, just 1 in 18 lakh units. The main battleground for this virus is purely blood-to-blood contact.
Now, because this disease is so slow, we're talking a 20-year crawl to cirrhosis in many cases, it is notoriously silent. In fact, the acute phase usually doesn't even cause jaundice. But you will often spot the clues outside the liver first. We call these extrahepatic manifestations. So, a patient presenting out of nowhere with diabetes, Hashimoto's thyroiditis, or Sjogren's syndrome might actually be hiding a chronic hepatitis C infection. Diagnosing this properly means you've got to step back and look at the bigger picture.
Let's head into Section 4,
avoiding the diagnostic trap.
When it comes to diagnosis, there is a golden rule. You have to stick to a strict two-step algorithm. Always start with an anti-HCV antibody screen. But, and this is a massive but, you absolutely must confirm an active infection with step 2, an HCV RNA test by PCR. Why? Because remember that 15% of people who naturally clear the virus? Well, their antibody test is going to stay positive, potentially for the rest of their lives, even though they are completely healthy and don't actually have the virus anymore.
This brings up a huge medical legal lesson. There's actually a famous real-world lawsuit about exactly this. A nephrologist saw a positive antibody test and wrongly denied a patient their routine dialysis access, just assuming they were actively infectious. Later on, a gastroenterologist actually checked the patient's RNA, and guess what? It was completely negative. The patient had just recovered from a past infection. The nephrologist was sued and had to pay compensation. The takeaway is clear. Anti-HCV positivity alone should never be used to label someone as actively infected. You need the RNA.
But hold on, because there's a major curveball to this screening rule. For your standard average patient, if that antibody test comes back negative, you can pretty confidently rule out the disease. However, for a chronic kidney disease patient on dialysis, an anti-HCV negative result does not rule out the disease. Since dialysis patients are often immunosuppressed, their bodies might not produce antibodies at all. For them, an RNA test is literally mandatory, even if their initial screen shows up negative.
And finally, Section 5, the 12-week universal plur. It wasn't even that long ago, we're talking the 2016 era, when treating hepatitis C was a complete, deeply complex maze. You had to run tests to figure out exactly which of the 7 genotypes the patient had, and then try to tailor these really complicated treatments that came with some pretty heavy side effects. Today, we've shifted into this beautifully simplified era. We now use pan-genotypic oral therapy. That means it doesn't matter what genotype you have, everybody with chronic HCV is treated with a single, simplified approach. Today's arsenal is brilliantly straightforward. We just combine an NS5A inhibitor, velpatasvir, with an NS5B inhibitor, sofosbuvir, right? That's your asvir and your uvir working together. You give this oral combination for exactly 12 weeks. It really is that simple. Now, if the patient's disease has slowly progressed to cirrhosis over the years, the regimen is basically identical. You just add the drug ribavirin to the mix for those same 12 weeks.
So, as we wrap up this explainer, it's pretty wild to realize how fast medical knowledge has to evolve just to keep up with these miraculous advancements. I mean, things taught less than 10 years ago are completely obsolete right now. We've got a biological understanding of a virus that stays strictly in the cytoplasm, and we have a perfectly targeted, simple 12-week oral therapy that cures almost 100% of cases. So I want to leave you with this final thought to ponder. With the science essentially solved, what is actually standing in our way of eliminating this disease forever? Is it general awareness? Is it finding and screening the silent carriers? The medical mystery is solved, guys. The next step is entirely up to us.